Hello? Hello? Am I audible? Hello? अच्छा but कुछ तो पता चले. Hello? Am I audible, sir?
Yes, yes, audible.
Okay. Good morning. Today I'll be talking about vitreous substitutes. Okay. So, what are vitreous substitutes? So, these are materials which are used to push the retina from inside in retinal detachment cases to attach the neurosensory retina with the RPE. What's an ideal vitreous substitute? It should be similar to the native vitreous, should be easily manipulable during surgeries, and should have similar viscoelastic properties as a native vitreous. Should be clear and transparent, should have refractive index and density similar to the native vitreous, should be biological and chemically inert, hydrophilic and insoluble in water, should be able to maintain the IOP, should be clear, should be non-toxic, should be biocompatible, and it should be easily available and stable, and it should be injectable through small syringes, and it should maintain its light transparency. So vitreous substitutes can be divided into gases, liquids, and polymers. In gases, so we'll talk about the intraocular gases first. So in the gases, we have non-expansile gases and expansile gases. In non-expansile gases, mostly air is used, and in expansile gases, sulfur hexafluoride and perfluoropropane are commonly used. So air is the first gas which was used in retinal surgery. It affects lasts for 3 days, and only small bubbles remain after 24 to 48 hours after injection. It's inexpensive, readily available. There's no need for its removal, as it gets absorbed by the eye and is replaced by the aqueous humor. Have non-expansile properties, so is not used as internal tamponade. Absorbed by the red blood cells, and so it diffuses quickly into the blood circulation. Have a low refractive index. So the problem with this is it causes complete light reflection. So post-op seeing the retina becomes difficult, and it is used in retinal detachment surgeries to maintain IOP after subretinal fluid drainage. Also used in pneumatic retinopexy. Sulfur hexafluoride. It is the most commonly used gas. It is 5 times heavier than air, colorless, odorless, non-toxic, and its maximum expansion is after 36 hours, and it doubles in its volume, and it disappears by 10 to 11 days. Mean is 12 days. And it is used as 30% SF6 with 70% air, and when it is injected into the eye, it eyes when it is injected into the eye, the nitrogen from the surrounding tissue diffuses into the gas bubble and leads to expansion of these bubbles.
Go
Perfluoropropane.
back to previous slide.
Yes, sir.
SF6, you are saying 30% is non-expensive.
Yes, sir.
Uh, Akash,
It's actually 20% is non-expensive. So I think 30, where you have written this 30% is in the source.
yeah. So for SF6, it is 18 to 20%. It's not
No.
30%. Where did
Okay.
you get this data?
Sir, I have read it from one paper, sir. So in that it's given
No,
like
might
this.
be
And
Hmm.
they
even
are using something different, but usually 18 to 20% is ISO expense, non-expensive or ISO expensive.
Yeah.
okay.
You have a table of all gases where half-life and Non-expansile percentage is given.
No, sir, I don't have that table. I did not find that table.
Okay.
That table is actually in the book, that Atul Kumar sir's book. You might have a PDF of sir's book. So in that book, they have a table of non-expensile or everything, days and what is it, time to get double the gas, and how much long time.
Okay. 18 to 20%. Can I go further?
Yes, yes, sure.
Okay. So perfluoropropane is 6 times heavier than air, inert, colorless, odorless, and non-toxic, and its duration of action is usually 38 days. And this is the table which I have got, sir. Only average duration of action is given here. And when does it reaches its largest size? Okay, so characteristics of gases. Surface tension, the gases have the highest surface tension among all the vitreous substitutes. And if the bubble is larger than the break, then the surface tension of the gas prevents it from passing through the break, and it occludes the break, and retinal pigment epithelium pump then can reabsorb the subretinal fluid. Buoyancy, it's the property to float. It provides the force that pushes the uppermost retina back and thus helps in opposition of retina to choroid. So gases are used for retinal detachment surgeries and vitreous surgeries. So in retinal detachment surgeries, they can be used in giant retinal tears, large break with fish mouthing, posterior breaks, restoration of intraocular volume following subretinal fluid drainage, total RD with the multiple breaks and large meridional folds. And in vitreous surgeries, they are used as extended internal tamponades. Post-operative care is the patient should be in prone position, and the IOP should be measured post-operatively after 6 to 8 hours, and a prophylactic AGM should be started. And if the patient is under general anesthesia, then nitrous oxide should be stopped 15 minutes prior to gas injection to avoid sudden expansion of the gas. Now, the complications of the gases is the contact of the bubble to the posterior lens can cause immediate postoperative rise in IOP. It can cause lens opacities, bullous keratopathy, and new break formations can be there, and it can cause subretinal gas migration. Now there is this, if the gas is injected into the vitreous base accidentally, then we can get this donut sign and sausage sign. So in donut sign, the gas encircles the posterior lens surface, and in the sausage sign, the gas partially encircles the lens posteriorly, and in both the cases, the bubble is immobile. Contraindication is large breaks more than 1 clock hour, or multiple breaks extended over more than 1 clock hour of retina, severe or uncontrolled glaucoma, patients who have neck problem or other problems who cannot maintain that posture post-operatively, and if the break is in the inferior 4 clock hours of retina, and in the patient who have to travel by air within 1 week. We'll go to liquids. Now, in liquids, we have perfluorocarbons, semi-fluorinated alkynes, silicone oils, and balanced salt solution. Perfluorocarbon liquids, they have higher specific gravity than water, so it sinks. Low viscosity, which favors its easy introduction and removal. It is not mixable in water. It's colorless, odorless, and inert. And refractive index is similar to water, and have vapor pressure, so evaporates fast. So available compounds here we have perfluorodecaline, perfluorohexyl octane, perhydrophenanthine, and octafluoropropane. Fluid anteriorly and can pass through the break. Thus, they helps in flattening the retina. In these, there's no need for posterior retinotomy, and in the PVRs, it is to be injected over the optic disc, and thus it helps in opening up the funnel and in dissection of posterior membranes. It pulls peripheral retina posteriorly and thus helps in visualization and dissection of membranes in anterior PVR. They also act as soft instruments, so they are also called as third hand. And in giant retinal tears, they can unfold the everted flap, and they also help in the removal of posterior dislocated lenses and IOLs. And they're also used in ROPs and in removal of subretinal and suprachoroidal hemorrhages. Complications, they can cause new retinal breaks, they can cause central retinal artery occlusions, subretinal migration, dispersion into multiple bubbles, and residual droplets. Semi-fluorinated alkynes, they are also known as fluorinated alkynes. They are colorless, immiscible with water, physically, chemically inert, and they are partially fluorinated alkynes, which are first internal tamponates, which were first internal tamponates agents that can be used beyond the intraoperative setting, even though they are heavier than water. They have a specific gravity of 1.35 gram per ml and a refractive index of 1.3. So here the low specific gravity is thought to produce less retinal damage. They are used as solvents for silicone oil and used for temporary endo tamponades for special cases of RDs when silicone oil failed to function properly. And clinical trials have shown that they can be tolerated for extended period of 2 to 3 months. Advantages are they're soluble in perfluorocarbons, hydrocarbons, silicone oils, and have a preferred refractive index. And they have a higher interface tension than silicone oil, so they can bridge the larger retinal breaks. Disadvantages are cataract formation and emulsification, leading to formation of epiretinal membranes and cellular material. Coming to silicone oils, so silicone oils are liquid polymerized siloxanes with organic side chains, and the chemical properties are as follows. They're clear, transparent, inert, non-carcinogenic, and heat resistant. Available in multiple various viscosity like 1000, 2000, 5000, and 10,000 centistrokes. They have a high surface tension, immiscible in water. Refractive index is 1.4, so which is slightly higher than the vitreal index of 1.33. They're lighter than water, hydrophobic, easy of removal, low toxicity and transparency. Commonly used silicone oils are as follows. Then their mode of action is tamponades. They act as internal and permanent tamponade in attaching traction-free detached retina, and this is due to its high surface tension. They are used as space fillers, and they also help in maintaining IOP. They inhibit diffusion of angiogenic mediators, so they helps in limiting rubeosis in PDR. Causes mechanical inhibition of membranous contractions, and they also causes homeostasis. So it tamponates the bleeder vessels in PDR and from the edge of retinotomies and retinectomies. So what are the changes in the optics after using silicone oils in phakic and pseudophakic eye? Due to the concave anterior surface of the bubble, it leads to hypermetropia of about +5 diopters. And in phakic eyes, due to convex anterior surface, it causes myopia. So indication is RD with proliferative vitreoretinopathy, giant retinal tear, traumatic RD, and diabetic TRD with rheumatogenic detachment. Advantages of silicone oil is easy.
Manisha,
हाँ sir.
silicone oil, one of the major indication is endophthalmitis with retinal detachments. No, उसमें भी as it works as a bacteriostatic. So the endophthalmitis eyes with retinal detachments is one of the indication for silicone oil. Also in retinal detachment with proliferative vitreoretinopathy, they will specifically ask कि कौन सा proliferative retin तो C3 से जो ऊपर का PVR होता है that will be the indication C3 के नीचे
Okay,
below
specifically more than 3 PVR. Okay. Okay sir. End off में भी use होता है detailing. Okay. Advantages are it is easy to remove, low toxicity, it is transparent and immiscible in the water, so high surface tension. High surface tension and low specific gravity creates a tamponade effect on the superior retina with 70% success rate in preserving anatomical integration. And it is preferable to use an silicone oil tamponade if post-operative aeroplane or high elevation travel is planned. Disadvantages, with a surface tension less than that of gas or saline, they can pass through the retinal break under traction more easily than gases. It's hydrophobic and therefore does not have the desired retinal contact. It is clear, but still its refractive index requires optical adjustments, and tamponade of the inferior retina is difficult given the low specific gravity of silicone oil. Emulsification is the problem with SOs. And silicone oils has also been reported to have caused problem with both native and implanted lenses. Emulsified droplets can go and attach to the silicone intraocular lenses, and post-operative cataracts are common with silicone oils. And here the patient must be followed closely for possible complication and possible complications. The removal process can cause complications. Therefore, careful clinical adjustment is required when selecting patients for silicone oil removal. And removal can induce or allow recurrent retinal redetachment in up to 67% of cases. And silicone oil removal has been accompanied by visual acuity loss, hypertonia, and corneal abnormalities. And there's this phenomenon of sticky silicone oil, which is adherent to the retina and has been reported to complicate its removal. Um, Anterior chamber migration can be there. Corneal decompensation and band keratopathy is another complication, and it can lead to glaucoma from pupillary block or overfilling, and hypertony from underfilling. Now, they also causes decrease in choroidal thickness 3 months following silicone oil implantation, and this may be caused by the failure of Muller cells to migrate potassium and the subsequent potassium accumulation, retinal degeneration, inner retinal and choroidal thinning. It can also lead to intracranial migration through the optic nerve to the lamina cribrosa and the optic chiasma with the development of central scotoma. So both these complications are very rare. So when do we remove these silicone oils? When the retina is attached, chorioretinal scars have formed, the retinal traction is absent. So usually they are removed after 3 to 6 months, but recommendation is from 6 to 8 weeks to 6 to 30 months. Silicone oil and SFA's combination. So when we combine these two liquids, the solution take advantages of high specific gravity of SFAs and the high viscosity of silicone oil in order to produce a vitreous substitutes with a good tamponade effect and minimal emulsification. So here we have two types, double fill and the heavy silicone oils. So in the double fill, the double fill is a mixture of silicone oil with the SFAs, where the heavier SFA supports the inferior retina and the lighter silicone oil supports the superior retina. So advantages, it reduces the dispersion and improves tamponade compared to silicone oil alone, effective in complicated retinal surgeries with large inferior retinal breaks, and it reduces emulsification compared to using perfluorohexyl octane alone. Disadvantages, it does not provide adequate simultaneous superior and inferior tamponade, and it results in egg-shaped bubble with less support superiorly. So conclusion is these are best for treating large inferior retinal breaks, but doesn't meet the original expectations for simultaneous support. Heavy silicone oils, these are made by combining silicone oil with PFAs to create a homogeneous, heavier than water solution. And they are usually used for long-term endo-tamponades in a complex retinal detachment with the inferior PVR. Advantages are they are more viscous, stable, and better tolerated than earlier versions. Longer retention time, that is 1 to 4 months, with less complications, and they have a high initial success rate that is up to 81%, and anatomically success 54 to 81% at 3 months or more. Disadvantages of heavy silicone oil is they're difficult to remove due to high specific gravity, and then again removal requires aspiration with 18 gauge needle, which can damage the optic nerve. They can complication they can leads to cataract, intraocular inflammation, emulsification, and elevated intraocular pressure. And some oils like HWS have the incidence of leading to posterior subcapsular cataract. Now coming to polymers, we have natural polymers, semi-synthetic polymers, and synthetic polymers. So in natural polymers, we have hyaluronic acid, collagen, and chitosan. So hyaluronic acid has been considered due to its native presence in the vitreous humor, but it have a high degradation rate limits in its long-term use. Collagens have been used in complicated retinal detachment cases, while modified forms like methylated collagen and chitosans are being explored as potential substitutes. Advantages, they have a better biocompatibility, and a clinical study demonstrated that hyaluronic acid was well tolerated with only mild inflammation and no cataract formation. Disadvantages is their rapid degradation, light weight, so they have limiting effect in inferior retinal tamponades, and they are inflammation and ocular pain is less. Semi-synthetic polymers, we have Hyaline, which is made by cross-linking of sodium hyaluronate with the formaldehyde, and they are investigators as vitreous substitute, but gel forms have shown issues such as migration through retinal holes into the subretinal space due to insufficient coherence. Uh, Advantages are semi-synthetic polymers, they may offer temporary vitreous substitutes and have potential for partial replacement. Disadvantages is that their effectiveness is long-term substitutes remains unproven, and migration issues further limits their clinical use. So semi-synthetic polymers have, like Hyaline, have shown some promises, but further investigation is still needed. So now we have some experimental substitutes. In that we have synthetic polymers like hydrogel, smart hydrogel, thermosetting gels. We have vitreous transplants, and then we have foldable capsular vitreous bodies. So hydrogels, they are also called as swell gels, and they are the three-dimensional polymers that expand in aqueous solution without dissolving. And they were the first biomaterials which were synthesized for human use. Synthetic hydrogels under investigations include the following: 1-vinyl, 2-pyrrolidone, acrylamide, copolyacrylamide, polyvinyl alcohol methylacrylate, polyglyceryl methylacrylate, poly-2-hydroxy hydroxymethyl polymethyl 1,2-acrylamide 2-methoxyacetate. So they are used for retinal tamponade and drug delivery. Disadvantages are activation. They cause activation of immune system, causing intravitreal inflammation and phagocytosis by macrophages in the vitreous, neuroretina, and subretinal spaces, and they're difficult to sterilize. Smart hydrogels, they are still under experimental stages. The advantage is that they have this, they create a three-dimensional structure in response to variety of signals, including the pH variation, temperature, light, pressure, chemicals, and electric fields. Thermosetting gels, they are being, again, these are also being explored for their potential as intraocular tamponade agents, as they gelate at the body temperature, which makes them suitable for use as vitreous substitutes. Advantages are their easy handling, transparency, and they maintain the intraocular pressure, and they no noticeable damage to the anterior segment lens or retina. Disadvantages is there have a potential drift. In a study with the WTG 127, the gel was observed to drift under a retinal tear, and this could be problematic if the gel moves under the retina. Uncertain biodegradation. Vitreous transplants, they began in 1946 using donor vitreous injected into the posterior chamber. 1947 rabbit study showed complication like vitreous haze. In 1976 human study in a human study, 200 transplants for retinal detachment, 400 reattachment rate was shown, and common complications like haze, uveitis, cataracts, and glaucoma were seen. proteolytic function. The donor vitreous helped dissolve vitreous bands but lost structural integrity during injection. So again, there was a halt in this uh, topic, and again further studies are needed for this. uh, Now coming to foldable capsular vitreous body, these were developed in 2008, and they consist of a thin vitreous shaped capsule, a drain tube, and a wall. So all these are made from modified liquid silicone rubber. The FCVB is folded during implantation into the vitreous cavity, where it is then inflated with the balance salt solution or physiological balance solution or silicone oil. The valve tube system helps regulate intraocular pressure and support the retina. Now, what is the future of vitreous substitutes? We have vitreous substitutes as drug delivery medium. Here usually hydrogels are being used here, and the challenges are the vitreous humor isolated by blood retinal and blood aqueous barrier is difficult to treat with topical or systemic drugs. So intravitreal injections are most direct method, but they have the drawback of rapid clearance requiring frequent administration. Now, cell culture and gene therapy is also under studies now. So, artificial synthesis, the vitreous via, so these syntheses are via the proliferation of halocytes, and this research has been aided by the use of reverse transcriptase polymerase chain reaction to analyze and compare the expression profiles of several genes involved in synthesis of the vitreous. Thank you.
Yes, Akash. I think one of the most important thing is that table. You should know the half life and exact percentages, because that will be asked in the exam, and also practically we use it all the time.
Yes, yes,
Okay,
yes.
sir.
This is one of the most common topic asked in theory exam as well as practical exam. So you should go to OT and see how silicone oil injected and how C3F8 and SF6 injected. So you will never forget that.
Okay, sir.
Nice presentation.
In case of macular hole, which is a good tamponade?
Gas, sir.
Manisha,
Gas.
why gas?
SF6 is.
Why gas? Why gas?
It'll keep the surface dry.
Shishir?
Excuse me, sir.
Yeah,
They do
why gas
use
in macular hole?
gases in macular.
Uh, Sir, one thing is the advantage is we need not have to go for re-surgery, sir, as there is no detachment, so the gas tamponade will be ideal because second surgery is not required, and it will keep the surface of the retina dry, and since the traction is eliminated, it will help in better closure of the holes.
Gas has more surface tension than oil. So
Yes.
actually, from the physics point of view, gas is better than oil for closing holes.
Uh,
Okay, but only thing is it requires strict positioning. And second thing is that it is self-absorbing. So if you want long-term tamponade, it's not possible,
Yes, sir.
yes.
right? And also with gas, what happens is that with oil, usually it is slow moving. Gas, it is fast moving. So in case the patient doesn't maintain good position, it has a reverse effect also,
Yes.
because when it moves faster, it pushes the fluid also faster. So if you have a
Mm.
brake which is not tamponaded by gas, in fact the gas will itself push fluid through that brake.
Okay.
Okay.
So macular hole, of course, another important thing is macular the hole. The position of the hole is very like useful for the gas also. because gas has maximum action on its top.
Oh, yes.
So that is where it has the highest pressure on the retina.
In at the posterior poles.
Yes, posterior pole.
Okay.
What will happen with the band if we put a band and then put gas? Anything
Sir,
changes?
then yes, sir, it will means compress the gas from circumferentially, sir.
Because the gas has higher surface tension, it tries to keep itself as a bubble, single
Oh,
bubble. So
hmm,
on the posterior slope of these bands, usually it gives least tamponade.
okay,
So if you have put band and then if you put gas and the brakes are on the posterior slope of the band, in fact you will have less tamponade in that area. Okay. So generally, if you plan to use gas, don't use band.
yes,
Okay, because more circular the cavity is, it will have better tamponading effect.
yes.
Okay.
Okay. Anything else? Any questions?
Sir, if like you said, macular hole patient, we should inject gases, but if the patient have to travel by flight, then is there any other option?
Yeah, you mentioned about that in the presentation about the travel also.
Yes, sir, it is
Contra-
contraindicated.
But
So
when
then
can
what?
the patient travel after the surgery?
I think 3 months.
What is the quantity of air or gas which is okay for the patient to travel?
Expansion after 4 to 6.
Uh, Percentage.
Sir, like better is when the gas is fully absorbed, sir. Around like if it is SF6, then around after 3 to 4 weeks you can travel, sir. If it is C3F8, then around 6 to 8 weeks, sir.
Right, right, correct. But for example, say patient wants to travel from Sangli, Kolhapur to Ratnagiri. What will happen to the gas?
It, no, there will be more expansion if they're traveling by flight, no?
No, flight though, okay, flight though we are
No.
not allowing the patient till the gas is there because in flight the variations are more.
Yes.
But
I
if they
think
are
the
traveling by road, say, but again there will be decrease
Movements.
change in the altitude na, between Sangli and Konkan, which is a coastal
yes.
area.
Okay.
So in that case, what will happen if you operate in Kolhapur and you have put gas and now patient goes to Ratnagiri?
Hyperbaric pressure will be more, I
There
think,
can be
like
changes in IOP, sir.
hypotony.
What will happen?
IOP.
Increase.
Increase. Acha.
Gas will expand or reduce?
Expand.
How will it expand? What is the
Reduce.
atmospheric pressure? It is lower in the higher region or higher in the air region?
It is
Oh,
more experience.
In Himalayas, the air pressure is less or high? What happens in flight?
The pressure is more, sir, in flight.
No, no. The pressure is not more. It is compressed. The cabinet is usually tried. They try to compress it, but actually pressure in the atmosphere is lower. No, outside
Yes.
flight.
Yes.
That's why
Yes,
when
sir.
there are fluctuations, suddenly the air pressure may drop and then the bubble expands. So
yeah.
Okay.
when they go from higher altitude, say from Kolhapur to Ratnagiri, actually the gas bubble becomes smaller.
Yeah.
The percentage is very less, maybe 5% or so. You can check. Okay. But you should understand that. So when patient is operated other way around in Ratnagiri and comes to Kolhapur, the volume is going to expand a little bit.
Expand.
Okay. Anyway, these are smaller changes because the height is hardly maybe 300, 400 meters. Right. Okay. Anything else?
Sir, how much of gas or gas we have to inject? Like percentile होगा, but still how much of the uh, volume of the vitreous have to be replaced with the gas?
How much of the vitreous has to be replaced by gas? Gas will fill up entire vitreous, na? Well, entire cavity which is free of vitreous. Also, it
So the
will
whole,
compress the remaining vitreous because it will dry out the vitreous.
okay.
So gas fill is usually complete on, unless
Yes.
you want air to be injected at the end of the surgery just for the port closure. Then you can put partial air in the vitreous cavity. But for tamponade, you need to have 100% fill.
Okay, sir.
Okay.
Okay. Thank
ठीक है, done.
you.
Okay.
Yes, sir.
Okay. Thank
Thank
you.
you, sir.
Thank you, Akash. Thank you. Bye.